Dr. Jason Leibowitz, and I'm a rheumatologist at Skylands Medical Center. And I'm presenting the poster on 30 years of follow-up in 3 patients with familial polyarteritis nodosa due to adenosine deaminase 2 deficiency. As we know, DATA2 is an autosomal recessive disorder that manifests with fever, early onset vasculitis, strokes, and hematologic dysfunction, among other signs and symptoms. And given that the first published descriptions of this condition were in 2014, not much is known about the natural history and course of this disease over many years. And thus, my co-authors and I looked at 3 sisters of Northern European descent over a 30-year period of follow-up. So these 3 sisters have been cared for at the Johns Hopkins Vasculitis Center for the past 3 decades. At age 7, the first sister developed rash, fever, lethargy, and a deviated right eye and was treated empirically for tuberculosis. At age 8, these symptoms recurred along with abdominal pain, hypertension, and stroke. Renal angiography demonstrated microaneurysms, and a skin biopsy confirmed the diagnosis of PAN. She was initiated on prednisone and azathioprine, and within the following year, she developed 2 bowel perforations with pathology demonstrating PAN and was treated with cyclophosphamide. By age 17, methotrexate was added for abdominal pain in the context of worsening mesenteric angiography. And at age 19, she developed mononeuritis multiplex and acute abdominal pain, and this led to the discovery of a ruptured renal aneurysm and upper GI bleed necessitating gastrectomy. She was treated with prednisone, cyclophosphamide, and total parenteral nutrition. From ages 19 to 25, she had 8 hospitalizations for abdominal angina and GI bleeding and 1 for stroke. Angiography during this period showed 95 to 99% stenosis of the celiac artery and diffuse changes of PAN in the superior and inferior mesenteric arteries, as well as active skin lesions. Her treatments included prednisone, mycophenolate mofetil, azathioprine, cyclophosphamide, and ultimately etanercept. And from age 25 to her current age of 44, while receiving etanercept, she has had no hospitalizations for active PAN, and she's been able to work and travel. The second sister in this family developed fever, mononeuritis multiplex, and cutaneous vasculitis at age 7. She did not respond to prednisone and was treated with azathioprine for 1 year. At age 8, she was transitioned to cyclophosphamide, but experienced persistent livedo reticularis. At age 23, she developed right eye blindness due to central retinal artery occlusion, and the same condition occurred in the left eye the following year. From age 24 to her current age of 40, she has not had ongoing PAN activity and has done well on treatment with prednisone, mycophenolate mofetil, and etanercept. The third sister in this family was diagnosed with PAN at the age of 6 with skin biopsy performed in the context of livedo reticularis, subcutaneous nodules, and mononeuritis multiplex. She was treated with prednisone and briefly with azathioprine. Since diagnosis, she's done well on pentoxifylline, aside from livedo reticularis that has been worse in the cold. She's currently age 41 and otherwise asymptomatic. Thus, treatment with a tumor necrosis factor such as etanercept has not been pursued. And none of these 3 sisters have developed hypogammaglobulinemia or hematologic abnormalities, except for anemia due to GI bleeding in the first patient. So we had the opportunity after 2014 to recognize the genetic component of what seemed like familial PAN in this family. And thus, we worked together with researchers at the NIH to perform genetic sequencing, exome sequencing performed in families with multiple members affected by PAN. In other contexts, has revealed mutations in the CECR1 gene that codes for adenosine deaminase 2. And indeed, in these patients, all 3 patients were found to be compound heterozygous for the same deletion on exon 7. You can see that represented in panel B in the results section in the figure with a pedigree chart in panel A. The parents are alive and have not undergone genetic testing. In panel C, we can further see the CECR1 mutation that's present in the 3 sisters and not present in a control patient. And then panel D and E, we were able to demonstrate that all three patients were found to have decreased ADA2 enzyme activity compared to controls. And this supports the diagnosis of familial PAN in the context of deficiency of adenosine deaminase 2. So there's several important lessons that we can learn from this instructive case of following these three patients over about 30 years of follow-up. Number one is that these cases demonstrate the wide spectrum of severity of familial PAN that provides evidence for variability of penetrance of expression of adenosine deaminase 2 deficiency. Number two, we can see the response to TNF inhibition in two of the siblings with the more severe disease that were treated with this therapy. And this is consistent with what we've seen in reports in the literature about the efficacy of this class of medications, TNF inhibitors. And number three, I think demonstrates the importance of long-term follow-up to understand the natural history of the disease, response to treatment, and ultimately to be able to identify genetic risk factors that have an impact on the knowledge of this condition for this family, and would certainly relate to screening in other family members if symptoms arise, and also for the purposes of family planning. So I'd like to thank you for your attention and appreciate this conference allowing us to speak on this topic. Thank you.